How's everybody doing today? Welcome to the next installment of the Cancer Forum here at James Clinic. So I'm guessing a few more people will hop on as we get going. This is the second one of these we have done. So what we've found as we have moved into the integrative space is a lot of people don't even understand what is integrative cancer care and what do we have to add that the traditional in the system cancer care doesn't address. So we're going to go over that today. It's going to be a lot like last time. I'll open it up for questions at the end. So feel free to drop those in the chat or just indicate by raising your hand and we will get to all of those. So I'm going to share my screen. And we will get started here right away. So for those of you who are new, I think most of you probably know with James Clinic, we are now in 4 states. So our home base is in the western suburbs of St. Louis. We're also in southern Iowa with a small satellite clinic. We have our new clinic up in the Detroit, Michigan area, and we're in North Carolina. So we do cover a lot of real estate. Today I just want to go over the theory of cancer and how that's probably a lot different than what you've heard about in traditional settings. What is our approach? How can we work with cancer teams or in addition to cancer teams or instead of for some people? And it does vary a little bit based on tumor. And we have a lot of, we start by calling it a treatment protocol, but really what it is a roadmap. So for those of you who don't know my entire backstory, I am a board certified general surgeon. I actually used to write the board exams and the critical care board exams. I was trained traditionally in surgical oncology, operated on a lot of people with colon cancer, breast cancer, melanomas, those kind of things. So all the talks that they give in the box, I've given most of them. I've been part of most of them throughout the way. So I know what they have to offer for the most part. But now we really become specialists in integrative medicine. And when you get into this field, it is really spectacular to me to see the things that, quote, traditional in the box medicine had left behind and moved on and skipped over in favor of these super expensive, high risk treatments that don't work as well. So obviously we became known for hyperbarics in COVID, and now we're using those tools and resources that we built out then for our cancer patients and their benefit. So there's a theory of quantum healing. This is actually much more fascinating than I can even start to get into today. But the basic concrete thing is if you get a paper cut, you don't ever question, like, is this going to heal? Is this going to go away? You take for granted the fact that that paper cut in a few days will be completely, totally gone, and there will be no evidence of that. The magic here is that your body doesn't know the difference between healing a paper cut and healing cancer, healing a major operation, healing a major illness. And there has been a miraculous recovery from every cancer on earth, even stage 4, late stage patients who are pretty close to the edge. This is a fact that we don't talk about a lot in traditional medicine, and I myself have been fairly conservative when counseling patients in the system. Even now, I want to be pretty realistic with expectations, but also knowing that there's a higher power than us and that there are these miraculous recoveries out there. So what is the theory of cancer? This is actually very, very interesting if you dig into it. So Otto Warburg, what I think in the early 1920s, was looking at cancer and said, basically the cancer cells go rogue. So normally our cells in our body use oxygen to make energy. And that's through a process called the Krebs cycle or oxidative phosphorylation or something that's super boring. And I never wanted to memorize when I had to, let alone now. But there's also a shunt off of that where the body doesn't use oxygen very well and it flips into anaerobic metabolism. So it uses sugar or it ferments sugar. So in some of the cancer circles, instead of calling it cancer, the big C, they call it chronically fermenting cells. These cells have gone rogue and they're using M&Ms and sugar instead of using the good stuff that the body creates. This was the predominant theory of cancer until Crick and Watson came out with the DNA theory. And when that came out, everything flipped because all the funding was going to DNA. And they said this is a genetic mutation, and we have to correct the genetic mutation in order to treat the cancer. Guess where that's gotten us? Almost nowhere. So now our treatments are much more expensive, and one could argue much less effective for many things. So we're going back to that old theory: cancer is a metabolic disease. And if sugar feeds cancer, how can we starve the cancer cells and yet feed and nourish the patient? So again, this is a little more involved than you may care to know, but here's kind of your normal cell. It uses oxygen to make carbon dioxide and water, creating 38 ATPs, or those are like, think of those as bars on your cell phone. 38 of those are made through the normal process. But if we shunt to this anaerobic sugar fermentation, you only get 2 ATPs. So it's a much less efficient way to make energy. This is what happens when your body, if you've ever been in like sprints or high interval intensity training, this is what happens. Your body goes into anaerobic metabolism. This is where you get lactic acid buildup and things like that. So that's not the normal way our body processes, but much less efficient at energy production. So how do we use that to benefit our patients? We start by doing a baseline evaluation. And one of the things I'm really excited to introduce is max VO2 testing. So we can actually, if you've ever seen a documentary on Olympic athletes, they wear the big masks and they're running on the treadmill to calculate how much energy they can generate, because he who can make the most energy is going to probably be the best at the sport. So we can use that same thing and test our patients and see how well is your body using oxygen to make energy. And it probably wouldn't shock you to find out that most people in the cancer realm are very low. They're very inefficient at being able to use oxygen to make energy. So we're going to go through the baseline testing. We're going to get labs. We're going to look at the body fat analysis report. We're going to look at things like the PNOE. And we're going to see what can we leverage. We're going to focus on 3 things. If somebody's engaged in traditional therapy, how do we help them heal from chemo, radiation, and surgery? These are not net negative. These are not, or I shouldn't say, these are not net positive treatments. Some of these have very serious side effects and consequences that even people on our team are suffering from right now. So we kind of get a baseline. Do we have neuropathy? Is there cognitive impairment? Is there weight loss? Is there weight gain? What can we do in that aspect? The next thing we want to do is make your body inhospitable to cancer. So if your body, this is the terrain theory. If you've ever heard the germ theory versus terrain theory, you make the terrain of your body so that cancer doesn't want to survive and thrive there. And that's really the best way to treat this overall. So if you've heard of like an acid versus alkaline environment, you want a nutrient-rich environment, you want low inflammation. There's actually some viruses that can lead to cancer. So you want to make your body inhospitable to those things that lead to cancer. Then we're going to talk cancer-specific therapy. So this is the very last thing we're going to deal with. And we'll get into those a little bit. So again, that baseline assessment, the PNOE, this is something we're still getting it launched. It's a really cool device. It's basically carried in a suitcase and it's on an iPad. You just come in and we can actually do a resting where you're sitting in a recliner, or we can do it where you're doing max VO2, where you're riding a bicycle or a treadmill. And we get a complete report on how efficient is your body at making energy. We look at a continuous glucose monitor. I don't know if you can see mine. Yeah, you can. So we put this little dial on your arm. It gives us a blood sugar every 15 minutes, and we can see how is your body responding to what you're eating, so that patients who choose to go a more ketogenic, low-carb diet can actually get real-time feedback to see what they're eating and how it's affecting their body. Of course, we are really big on getting a full panel of labs. Interesting to me was that some of the immunomodulator drugs that they're using in traditional therapy, these medicines are $10,000 to $40,000 a month. Guess what? You have to have an adequate level of vitamin D in order for those drugs to work. Guess how many patients have come to me with a vitamin D level on those medications? 0. Because nobody in the integrative cancer world checks, or in the traditional cancer world is actually checking vitamin D levels and actually checking to make sure that a patient can use the medications that they're prescribing. I do a lot of Genova stool testing. This is a test. It's not like a Cologuard. It's not like any other test you've had unless you've seen a doctor like me. It looks at digestion, absorption, inflammation, and your microbiome. It looks for things like parasites, bacterial overgrowth, immune activation. So it's a pretty detailed test, especially for hormone responsive cancers, thyroid, breast, uterine, ovarian, and prostate. It tells me how well the body is detoxifying and getting rid of estrogens. In addition to that, in specific patients and indications, we do urinary hormones. So this is going to be probably a little bit similar to the Dutch test, but not exactly. Mycotoxin testing, if I've had a patient who's got exposure to that, and then heavy metals. So we have all kinds of specialty testing that we can do above and beyond just kind of that really good baseline. And literally out of hundreds and thousands of patients, almost nobody comes to me with a full panel of labs. I can probably count on two hands how many people have a really nice, thorough lab assessment before they get to us. So healing from traditional therapy. This to me is where I want to start with patients, because we all know somebody who's going through chemotherapy, who has a cancer diagnosis, who doesn't feel good, right? They're sick from the treatment. One of the members on my team told me she was so sick from chemotherapy, she thought she was going to die because she was weak, she was anemic, and nobody was listening to her and taking care of her. So this hits pretty close to home for us. The fatigue, the neuropathy, the cachexia, all of this, there are actually specific treatments that you can start to add. A lot of people, if you've ever dealt with a cancer doctor, what do they say when you ask, what kind of diet should I do? It doesn't matter, just make sure you don't lose weight. That is exactly the wrong thing to say, because they told my own family member this. It doesn't matter what you eat. Diet doesn't have anything to do with it. I would argue diet has everything to do with it, because it is the most important drug that you take in the biggest dose over your lifetime. Surgical, I have patients who have all kinds of wounds that are healing or they're going into surgery. And when we contribute to a pre and post-op protocol for patients doing IV vitamin C and hyperbarics, they have such accelerated healing that almost 100%, they go back to the office and the doctor says, what are you doing? You look better at 2 weeks than most people do at 2 months. You look better at 3 weeks than most people do at 12 weeks. It is unbelievably accelerated healing. So I want every patient that we have to have the benefit of that, because the longer it takes your wound to heal, the more of a setup of complications there are. And then when we're looking at radiation, anybody who's had radiation knows you can have, depending where they're radiating, skin burns is very common. Certainly if they're radiating in the pelvic region for like prostate cancer, cervical cancer, having colitis is very, very common, uncontrollable diarrhea and other collateral damage. And there are certain things that we can do to mitigate that damage so they can have the benefits of the treatment without the side effects. And one of the most common things that I hear is the radiation oncologists tell patients don't do hyperbaric oxygen. Well, radiation colitis and radiation skin burns is actually one of the insurance-approved treatments for hyperbaric oxygen, remarkably. And in order for radiation to work, guess what you need to have present? Oxygen in the tissues. So hyperoxygenating your tissues is actually helps their treatment work better. So I guess I skipped ahead of myself. So food is either contributing to your health or it's contributing to illness, and you have to decide. I have a patient, I really, really like this patient, called really frustrated a year into treatment. My gut is awful. I can't function. I can't do this. I can't do that. What did you eat for breakfast? Dr. Pepper and Funyuns. I said, do you think Dr. Pepper and Funyuns is a recipe for having a healthy gut? Do you think you can spend money on supplements to overcome the damage that you're doing with that diet? You can't, and I don't want you to. You got to, I can give you the roadmap, but you have to follow it. You have to do your part. So sugar feeds cancer. This is not a cancer patient, by the way, but sugar feeds cancer. So we have to get sugar out of the diet. And that is not just straight sugar from a soda can. That is rice. That is all the things that convert to sugar in our bodies. So getting them to a low carb keto diet is going to be one of the things that when you listen to most integrative doctors who've been doing this for years and years, that's really where they see the turnaround in late stage cancers. Like I said, most traditional doctors do not even include this in their plans. And when you're looking at somebody who's cachexic, right? They're losing weight because their cancer is so far advanced, it's really hard to tell them to calorie restrict or to restrict any nutrients. But if they go out and eat a Snicker just because they're trying to get calories in and gain weight, are they feeding themselves or are they feeding the cancer? They're feeding the cancer, so they're actually making their cachexia even worse. So there's an entire protocol that we can start to utilize that can get them in the gear of that. So things that can help, again, that continuous glucose monitor, I just cannot overestimate enough how powerful this can be for patients. I've had so many patients turn their life around because they just have the data. They don't like to see that number go up and fluctuate during the day. So lots of weight loss, lots of improved health, better sleep, less fatigue with just that. Keto Mojo is something you can actually use. It's a finger prick device to track ketones in the diet. And some patients can even take exogenous ketones for that. So again, when it gets to diet, when we see patients that have a new diagnosis of cancer, they're extremely overwhelmed. They've got a lot of emotional stuff they're processing. They've got all these doctors telling them different information. They've got all these appointments. Am I doing the right thing? They've got some big decisions to make. And then I don't know if you've ever been in that position, but do you know how many really helpful friends and family start to tell you things? It's very counterproductive. So I try to keep it really simple as step one and work through this as a process. So just reduce processed foods. Try to reduce what you're eating out of a package. Try to get to more real whole foods and don't worry so much. Try to eliminate that Pepsi that you drink 4 or 5 times a day. Try to get the easy stuff out and then we'll refine as we go. Because I don't want to make this so hard that they give up and they get overwhelmed. One of my favorite resources, I use this for cancer patients and non-cancer patients alike, is the book Glucose Revolution. It's a fantastic book. It's very accessible to everyone. And basically she teaches you how to eat so you don't spike your blood sugars. To me, this should be taught in school. This should be part of health class because it's the order of your food that's critically important. Really important because we always think of blood sugar as the problem. Sugar is the problem. Sugar feeds cancer. How does sugar get into the cells? Insulin. Insulin is the real root problem behind high blood sugar. And when we check things like insulin, like growth factor, we check fasting insulin levels. I think the highest fasting insulin level I've seen in a patient is 50. It should be between 5 and 10. Your body should not be cranking out a lot of insulin when you're not eating. That is a sign your body is not processing insulin well and not using it very efficiently. And then, like I said, maybe step 3, we get to high intensity keto, or for some cancers, that's a really more important part of the plan than other cancers. There's a little bit of controversy when it comes to hormone-based cancers, whether you should be like dirty, they call it dirty keto, where you're eating dairy and red meat and things like that versus a clean keto or more of a Mediterranean diet. Me, I'm not picky. If you're going to make a big life change, you do what's accessible to you. So vitamin C infusions, this is really going to be a linchpin of what we have to offer patients. So why does this work so well? Vitamin C is taken up by cancer cells and it stays in the cancer cell for 48 hours. So we really need to be doing these infusions 3 times a week. But why does it kill cancer and not hurt healthy cells? So when vitamin C gets in healthy cells, it gets broken down by an enzyme called catalase. When vitamin C gets into cancer cells, it doesn't have the enzyme catalase. And so what happens is it metabolizes and becomes hydrogen peroxide, which then think of it as when you see hydrogen peroxide and it bubbles up, it does the same thing in cancer cells and gets rid of them. So this is why it's such an effective treatment. A little background on this, I think it was in the 70s. There was a group that did a study and they looked at taking 10 grams of vitamin C orally plus 10-gram infusion every day in stage 4 pancreatic cancer. So we all know stage 4 pancreatic cancer has a very short lifespan. And what they found is they got these patients out like 4 to 5 times the life expectancy of normal. Mayo Clinic repeated the study, but they did it without the IV vitamin C. And guess what they went out and told the world? vitamin C doesn't have any impact on cancer. Well, here's the important thing. You have to give vitamin C IV. You cannot get high enough doses orally to make this effect. So when you give vitamin C orally as a low dose, it's an antioxidant. So when you listen to traditional cancer doctors, they say, I don't want to give an antioxidant. I'm trying to use oxidation to kill cancer cells, and you're blocking what I'm doing. But at high doses, vitamin C is a pro-oxidant. So it is going to work in line with those chemotherapeutic agents. This is one of the subtleties that is not well understood. So IV vitamin C is what you have to do. The oral is not adequate, unfortunately. Now, I'm going to go back to this for 1 second. We do oral vitamin C. The reason we do that is because in some studies, they were checking vitamin C before and after the infusions. And what they found is the body was so deprived of vitamin C that when they started infusing it, the body absorbed all the vitamin C and they could never get to the levels therapeutic because it was all absorbed by the body. So we give oral vitamin C 8 to 12 grams a day, 12,000 milligrams. We put it in a bottle of water like this and have the patient drink on it really slowly over 12 to 16 hours so that we can fill up the body's stores of vitamin C. Vitamin C is an essential nutrient. We cannot make our own vitamin C. We have to intake it. Then what happens is if our bodily stores are full of vitamin C, now when I'm doing the infusion, I can get that level up where it needs to be to kill cancer. So that's why we use oral vitamin C in our treatments. Vitamin D, so the level we shoot for is 80 to 120 at least. So I'm loading people with 50,000 a day of vitamin C for 2 weeks and then convert to 10,000 a day. You want to use K2 with it, D3 plus K2. D3 pulls calcium into the bloodstream. K2 makes sure to usher it to the bones. Now, one of the mistakes a lot of people make when I ask them, what's your vitamin D level? They tell me their vitamin D dose. It doesn't matter how much you're taking, it matters what your level is. And we have to check that with the blood. So melatonin is one of my favorite things that I've added lately. I myself take 60 milligrams a couple times a day, which is a pretty big dose on its own. But for my cancer patients, I'm trying to get them to 150 twice a day. And you want to do this during the day, not at night. So at night, your own melatonin levels are high, which makes the cancer less active. So we want to boost those melatonin levels during the day. And there's a ton of fascinating research on melatonin. This is actually a list that I stole from the Facebook group, How to Starve Cancer by Jane McClelland. These are 17 different mechanisms for how melatonin treats cancer or inhibits cancer. So I won't read through all of them, but I'll hit a couple of the highlights. First of all, it blocks angiogenesis, which is blood vessel creation. So think of a tumor cell that's really small. As it gets bigger, it needs blood vessels so that it can feed itself, right? That's the only way a tumor can grow. Otherwise, it doesn't go anywhere. So melatonin is going to block the ability of the body to make new blood vessels in the tumor. It can kill off the cells. So apoptosis is when a cell reaches the end of its own life. ER stress, so this goes to energy production in the cell. Nutrient starvation of the tumor. Suppression of metastasis. So a lot of things we're going to do are going to be to keep the cancer from spreading. Epigenetics is a really interesting thing. I don't know what percentage of patients come into my office and they say, this runs in my family. Every female in my family has breast cancer. It's genetic. I have this genetic thing. Genetics is only 20% of your outcome. 80% of it is lifestyle. So you've got these genes, and it's just like, think of it like a piano. You've got the genes, but what you eat and how you send signals to the body is what plays the melody. Does that make sense? So if I have the genes for breast cancer and I go to McDonald's 6 times a day and I'm doing the double Big Mac and I'm coming home and eating 4 Snickers bars, that is a very different melody that's going to play on my piano than if I'm eating broccoli and green smoothies and wheatgrass and eating a ketogenic diet. That's going to activate very different genes to turn on and turn off than the fast food diet. Okay, so don't get stuck in the gene argument. It is epigenetics, how those genes are expressed. Cancer stem cells is huge. This is where traditional medicine totally misses the boat. They target adult cancer cells. So you've got these cancer stem cells in there that they basically can turn into anything, or they're the baby cancer cells. Our treatments, vitamin C, melatonin, things like that, are going to knock out the cancer stem cells. Really critical. I'll let you read those. The inverted pH gradient. So I talked about acidity and alkalinity. There's a lot of theory around that, and that you have to be alkaline in order for your body to fight cancer. Chemosensitizing. So it's going to enhance the effectiveness of chemotherapeutic drugs. So everything we're going to do, think about it. In the box medicine, they're trying to kill cancer, and they hope they don't kill you on the way. They're tearing down, they're fighting the cancer. You just happen to be in the way, right? You just happen to be the one that has the cancer. We're trying to build your body up so that your immune system can clean up the damage. Totally different theories. And you can do both at the same time. So radiosensitizing as well. So it's going to make that radiation therapy work better. And it's also going to protect your healthy cells that are exposed to radiation from the damage. So I will wrap here and open it for questions, but the most important thing to me is that patients just want to get better. They don't care if that has the label chemotherapy or radiation or vitamin C infusion. They just want to get better, and they don't want to feel like skunk on the way, right? Most of us want to keep living our lives, going to work, keeping our jobs, staying in touch with our families while we're undergoing treatment. So the fact that what I have to offer just happens to have the label of outside the box integrative medicine doesn't make it any less effective than the traditional. It's just fewer people know about it. And at the end of the day, I'm not partial to how somebody gets better either. Whatever your own intuition and gut tells you, we will support that. Unfortunately, 80% of patients would like an integrative approach where they work with multiple facets, and oncologists are among the least likely to entertain these treatments and these discussions. I think I shared last time that my mom's best friend had a really tricky diagnosis with metastatic small cell carcinoma. And basically she held me when I was a baby, just home from the hospital, and I offered to treat her, and her doctors told her not to do it. And she died a horrible, painful, miserable death that my mom had to watch. And her doctors were so ignorant that they told her, don't do these things, even though she had open access to them. Nothing is so awful. And luckily, I didn't experience it firsthand, but it was really, really hard when my mom knew what we had to offer, that her best friend in the whole world didn't have access to it because they trusted the people who didn't know their middle name. Keep in mind, too, that the things we're offering are backed by data. They are backed by data. Just because the doctors in the box don't know the data doesn't mean it's not supported and backed up by that. Keep in mind, nobody has a profit center of vitamin C infusions. Like, nobody's going to get rich off of that. Nobody's charging $40,000 and $50,000 a month for vitamin C infusions. So these are small studies that have to be extrapolated. These are older studies, and these are studies that have been silenced because, again, it disrupts big pharma and their profit centers of these expensive drugs. So a few things, a few points to make to people. This is probably one of the aha ones. If it was really helpful, the big cancer centers would be offering it, right? How come this little clinic off of Manchester Road knows about it and the Stillman Cancer Center doesn't? And the only thing I have to say is they're biased to big pharma. They don't even know where to get an IV vitamin C infusion unless they're doing it personally. So this is not on their radar at all. They are incentivized to not know about it. They are incentivized only to know about the things that drive their profit centers and that they offer. So they have a biased offering and treatment plan. Again, friends and family will try to be helpful by telling you stories about this doctor and this experience and something that went bad and something that went good. The night before my mom had a double mastectomy, one of the local doctors stopped by and said she's absolutely doing the wrong thing. That is not helpful to people. So you kind of have to, if you're going through the process, you kind of have to block out the noise. That's why I tell people, if you know about us and you know somebody who could benefit, maybe just share our contact information. You don't necessarily want to oversell it. You want to let them discover it on their own at the time and place they're ready. Some patients are going to die because they want to be polite and not offend their oncologist. I don't know how many women come to me and with breast cancer and say, I don't want to take tamoxifen. I don't want to do anastrozole. I don't want to do letrozole. Well, tell them. You can't ask them, because if they tell you to stop your medication and you have a recurrence, they have presumed liability. If you tell them, I'm not going to take this treatment anymore because it's making me sick, that takes the liability off of them, and you might get a much more honest approach to that. And again, I'm not necessarily against traditional therapies. I did surgery. I recommended radiation. I had patients in chemotherapy my entire career. We just have a lot more tools in our toolbox now to help them get through it in a better way. So if you know somebody who's interested in doing this, what are the next steps? A consult with us is $14.90. That gets them started with our nurse, a complete consult with myself, all of the blood work review and the stool test, additional testing, and gets them started with those. The IV infusions are obviously separate. This is for the medical care component. And then $199 a month gets them in our concierge plan so that we can look after all these things while their cancer doctors are paying attention to their cancer. And honestly, for these patients, if they're doing the vitamin C infusion, it almost pays for itself to do the concierge because they get 10% off their infusion. So I think that's a wash at the end of the month. We also have the cancer stack, which is our vitamin D, vitamin C, melatonin that they can order as a bundle so that they have everything. One last thing I want to comment, we are part of the FLCCC study. That is an observational study. They do not have a treatment protocol. We are volunteering our data to submit. So we do have to have consent from our patients, a consent form to have the data included. And then we need follow-up, and this follow-up is out 5 years. So when somebody sees us, we're wanting that long-term data. And I really hope patients can get to us before it's too late. We've had a lot of people lately that have literally been discarded and told they have 3 to 5 days to live, and they're calling us. We're happy to listen and try our best to help. We need to get there a little bit earlier, I would say, and we try to be very realistic with what we can and can't offer. And if I think it's a Hail Mary, I tell the family, this is a Hail Mary. I'm willing to throw the ball if you want to, but I want you to know I don't think this is going to be the outcome you're looking for. So we try to be really, really honest about that as well. But if we can get to them earlier, all the better. I will entertain questions now. If there are any, you can drop them in the chat or go ahead and speak up. So I'll go ahead and, yeah, go ahead, Tracy. You're muted though, my dear.
Hi, can you hear me now? Sorry about that. I was wondering what is the outcome for brain cancers and all this?
Yeah, so it depends if you're talking about a primary brain tumor or if you're talking about metastatic disease.
Yeah, I'm talking about primary.
Mhm.
Yeah, I have a friend who has like some kind of really rare cancer she's an adult, but they find it mostly in children, and I'm not sure what it's called.
Yeah.
But she's finished with all of her treatments now. And of course, she went to the school where they said, eat anything you want. And, it was just, it's just a sad kind of thing. She's in remission right now, and I don't know her really personally. Long story short, but I know her mother, and just trying to, like you said, you can't just bombard somebody with that kind of information. And I just was trying to figure out how to hand off some information to them because she's in remission now, and it's just, it's a time bomb.
Yeah. So one of the challenges that those patients face is radiation necrosis. So if they've had whole brain radiation over time, that can cause its own damage. We had a patient that came to us that got biopsied for that afterwards. So there is a little bit different approach, I think, from us, which would be focused on low carb, ketogenic, really dropping the sugars, getting things across the blood-brain barrier, MCT oils, things like that, high dose melatonin, metformin. So it's a very different approach depending on what they have. That's going to be a lot different than metastatic,
Yeah.
but I can't say what the outcomes are. We're a little bit new to this, so I can only piggyback on the experience of others to say I would be much more optimistic if I knew we were doing an integrative approach and covering all of our bases. Yeah, so great
Yeah.
question.
Okay. Thank you.
Yeah, thank you. Hey, there's a couple questions from the chat, so I'm going to put these in here. I thought you added ivermectin to your protocol for cancer. I'm so glad you asked that. So I do. I offer ivermectin, especially for solid tumors. To me, it is not the most important thing that we do. So ivermectin and fenbendazole both have synergistic effects. Yes, we do add it. Do I think it helps? It may move the needle enough to justify it because it's really low risk. But again, if I only have X number of dollars to work, I'm going to prioritize IV vitamin C infusions over ivermectin all the time. And especially the a ketogenic diet, getting that. Any alternative preps for a colonoscopy? Oh boy. Ugh. No, I don't think so. You really have to bite the bullet on that one. You can make your own at home with magnesium and sodium bicarb. I have the recipe for that. But at the end of the day, you've got to get things cleared out. So, will this be available to watch again? Yes, I absolutely. So as you notice, I recorded this, so we're going to be posting this to our YouTube channel again. And you can find the link there. We're going to change the format, I think, for next month so that you have to register with an email, and then the recording will be automatically emailed to patients. Oh, this is a great question. Do you recommend a colonoscopy? My mom had colon cancer, so insurance won't pay for Cologuard. So let me start with Cologuard. I'm not a huge fan of that. And here's why. I'm old school. I used to do colonoscopies. It's super glamorous, I know. But I've done my share. I think everybody needs a colonoscopy at age 50 and probably another one around age 70 if it's a negative colonoscopy. The recommendation, as you know, is every 10 years. To me, the Cologuard, if you already have a family history of cancer. Oh, I froze. Sorry, I don't know. I don't recommend the Cologuard. I recommend the colonoscopy. You do need to bite the bullet and do that because if we find polyps and we can remove them, that stops the process. There also are some things like fiber can reduce the risk of colon cancer over a lifetime, reducing inflammation in the colon. So if you're eating things that cause an inflammatory response in the gut, cutting those out and cutting those down are going to be critical. So that's a great question. Good questions. One of the common things we get is, will you work with our other doctors? And my answer to that is, I can pretty much work with anybody. They don't always want to work with us. So, anybody who has an open mind and is willing to collaborate with us, absolutely, we can do that. I caution patients to broach the topic slowly. If you're going, I used to advocate, tell all your doctors what you're taking, be open and transparent. It's a new day and it's a new world, and that doesn't always work out really great for people. So you do have to be careful and filter what you're telling some doctors. You can throw it out there. What do you think about vitamins, or what do you think about ivermectin, and just see the response you get. And some of them are indifferent. I'm okay with the indifferent people. I can work with that. I can't work with the people who say, if you do that, you're not my patient anymore. But I also tell patients, if that's the way your doctor is, you might need to find a new doctor anyway, because they're not in line with your values and your beliefs. Do I recommend people take a Genova stool test if they also do a colonoscopy? Yes, I do. Two very different sets of information. So the Genova stool test is going to tell me a lot more about the microbiome, but I wouldn't do the colonoscopy followed by the Genova stool test because it might throw off the microbiome. So I would either do it a month or two before or a month or two after. So I would space those out. Oh, thank you. I've highly recommended you. Two of those are now patients of yours. You're amazing. Thank you very much. I appreciate that. We love the opportunity to help patients. My entire team, if you've engaged with them, they absolutely have a passion and a heart for patients. And we love the opportunity to be part of their story and help them through, especially when they're scared and they need that guidance. So, oh, can you go back and address the metastatic brain question? Yes, I can. So if it's a metastatic tumors to the brain work to me, operate a little bit differently than primaries do. So we're going to focus on treating the primary underlying that. again, a lot of the things there's going to be quite a bit of overlap just because there is, but hyperbaric oxygen may be more at play. I'm a huge believer, I didn't talk about this either, the MAH, the IV ozone treatments are phenomenal. The ozone actually gets in there, it buffers the antioxidant system, and it's great for resetting NAD, the energy production centers. So yes, it is a little bit different. We have a patient right now who we diagnosed with a metastatic lung cancer in her brain. It's really sad because she's very much likes the integrative treatments. She just because of she didn't have insurance and she didn't have finances, so we sent her to the emergency department once we found the tumors. She was enrolled in Medicaid and got $100,000 worth of whole brain radiation. She can't get a $200 IV vitamin C infusion. So it's when you look at things like that, it is legal money laundering, and it is the system that controls the treatment people have access to. So I hope that answers your question. Now, a year out, doing okay, having some seizures, but other than that, and again, we work with her doctors, right? I'm like, don't stop your seizure medicines, don't stop your steroids. Like, you need to be on that, but we need to address your elevated blood sugars from those steroids. So I appreciate the recommendations and the kind words. We work really hard to expand what we're able to do and competent in doing, and bringing more and more services on all the time that benefit patients in this arena. So I appreciate it. I'll take any last questions and then we will wrap for the day. And thank you for being here. We will do this the first Monday of each month. This is just a no obligation, no commitment way people can kind of explore what we have to offer and see if this is something they want to consider in their own treatment. Okay, everyone have a blessed day.
Thank you.
Yep, thanks. Bye.
Bye.